Dear colleague, my name is Stephane Gaudry. I am intensivist in ISICEM Hospital in Bobigny in Paris area. I would like to thank the scientific committee for the invitation for this talk on acute kidney injury and COVID-19. This is a very important talk during this sanitary crisis, I think. So I have no conflict of interest regarding this talk. The research timeline during COVID-19 is interesting. In December, China alerts about this new respiratory disease, and the identification of this new virus was provided in January, and the first epidemiologic studies published came from China and published in February in the New England Journal of Medicine. And the first paper who were interesting in extrapulmonary organ failure during COVID-19 was this paper on liver injury. And we had the data on acute kidney injury only during April. This was this interesting paper from the American Journal of Nephrology. And we have now more data. At the beginning, this study was interesting for this question because we have a very conflicting result. In this Chinese study, the occurrence of acute kidney injury was very low, 0.5, but in this study from New York City, the occurrence was 22%, which is a very different result that's led some nephrologists to ask, is the risk of acute kidney injuries with COVID-19 truly this low? We know that there is many unspecific reasons to observe acute kidney injury in our patient in ICU: the lung kidney crosstalk, the inflammation, the hypoxemia, the hemodynamic disturbance, and we use different nephrotoxic agents. Our patients experience hypovolemia, and sometimes they had sepsis. But we now know that this virus may impact the kidney directly. This very nice paper was published in intensive care medicine, and I think that you will have the talk in the same session on the pathophysiologic disease. But I would like just to show you that you can see virus impaction in proximal tubule cells and podocytes. So it's probably the reason why there are specific kidney aggregation. In June, this study was published in Critical Care. This is a systematic review and meta-analysis, and the occurrence of acute kidney injury in COVID-19 was 9%, but it's a mean percentage, because you can see that the study are very give very different results, and we need more data on severe acute kidney injury in COVID-19 ICU patients. Very recently, our team published this study, this observational study on AKI and COVID-19 patient, on severe AKI in critically ill patient. The objective of the study was to assess the occurrence of severe acute kidney injury defined by KDIGO 3 classification AKI in this patient with COVID-19, with severe COVID-19. And we ask for the mortality for these patients. So we perform an observational retrospective study who took place in March. It was a multi-center study in France and Spain, including 4 hospitals and 9 intensive care units. We include patients with ARDS, according to a Berlin definition, with a confirmation of the SARS-CoV-2 infection on the RT-PCR. We did not include patients who had chronic kidney disease at end stage, and we did not include patients who experienced cardiac arrest before ICU admission. We collect data on nephrotoxic drugs, antiviral treatment, respiratory parameters, comorbidities, the demographic data, the inflammatory markers, and vasopressors. And our aim was to assess the occurrence of Cadigo 3 AKI during the first 7 days after ICU admission. We have looked at the renal replacement therapy and the outcome after 28 days. On the 302 patients admitted, 211 patients were analyzed. And on these 211 patients, 70% had Cadigo 1 and 50% had Cadigo 2 within the first 7 days. And the very important result is that on this patient, 26% had Cadigo 3 AKI within 7 days in the ICU. The median time for the occurrence of severe AKI was 3 days, and 54% of patients with severe AKI receive renal replacement therapy in the ICU, which is in line with the percentage of patients who receive RRT in the study on the timing of RRT. The outcome after 28 days in these patients with severe AKI, 56% of patients had died after 28 days, 22% were still in ICU, and 22% has been discharged alive from the ICU. The patients who developed Cadigo stage 3 were more likely to have chronic kidney disease, higher body mass index, and higher SOFA score. They receive higher PEEP, and they receive nitric oxide therapy or vasopressor support more frequently. We performed this analysis on risk factor from mortality. This is a multivariate analysis. And as you can see, Cadigo stage 3 AKI is highly associated with mortality. The two other parameters associated with mortality in our study were respiratory SOFA and the age of the patients. We can compare our result to other cohort, non-COVID-19 patients. In the BACIT study, published in BMC Nephrology, the percentage of Cadigo 3 AKI was 16%, and in a secondary analysis of lung-safe study, it was 15%. So we can say that we observe more frequently patients with Cadigo 3 AKI in our study on ARDS patients with COVID-19. So the conclusion of the study is that severe acute kidney injury is frequent, very frequent in patients with ARDS COVID-19, and it is a risk factor for mortality. However, I think that this is just the beginning, and we need more and more observational study to answer the question of this on the epidemiology. And I think in the few weeks and few months we will have more data. Thank you very much for your attention.